Hi guys, welcome back to Snapshots. We'll next gonna talk about nephrology image-based questions. And first up is this 25-year-old guy in whose urine examination the following crystals which are shown in the image were present. He's had two episodes of flank pain radiating to the umbilicus in the last 3 months, which has required hospitalization. So the clinical history which is given in this question is that for renal colic. I mean, every time you read the statement flank pain radiating to the umbilicus, we're talking about renal colic in the person. And then he's asking you which of the following are correct about this patient. So it's more of an inset based question. And what you can see here on the image are envelope shaped crystals. So anyway, I mean, this would be easier to pick up the envelope shaped crystals because of the characteristic shape that you can see. And at this juncture, I can say that the most common kidney stone has been discussed here, that is calcium oxalate. Now, what you should be knowing here to solve this MCQ is that what is the number one cause or development of the commonest type of kidney stones? I mean, suppose a non-medico is asking you that, sir, why am I having development of this calcium oxalate stones? I've stopped taking milk, cheese, or dairy-based products, but still I'm having recurrence of these stones as well. So you would explain to this guy that, sir, in your body, serum calcium is normal, phosphate is normal, SAP is normal. I mean, the standard blood reports are normal, but the handling of calcium by your kidney tubules is defective. I mean, a non-medico would not understand this term, which you guys can. Idiopathic hypercalciuria is one of the leading causes for development of the commonest type of kidney stone, that is calcium oxalate stone. And as I said, I mean, what's the problem in this patient? The 24-hour urinary calcium of this patient is increased as compared to normal because of a defective handling, though his serum calcium is normal. So option A is the correct one. Perform 24-hour urinary calcium, because you need to document that this chap has a idiopathic hypercalciuria. Now, a lot of these people, they stop taking milk, cheese, etc. because they try to read about their illness from the internet, and there are a lot of websites which would tell them that stop taking calcium-based products. Well, what I want to tell you is that restriction of calcium has shown a paradoxical increase in the frequency of recurrence of calcium oxalate stones. So they should not cut down on calcium intake. Rather, the calcium intake in this patient should be about 1200 milligrams per day, that I've discussed in the routine lecture on kidney stone / nephrolithiasis as well. What they need to cut down is not calcium, not vitamin D3. What they need to cut down is salt intake. Yes, guys, just like in hypertension, we study about DASH. Remember dietary approaches to stop hypertension. I mean, to people with hypertension, we will say cut down on salt intake and take more of potassium. The same approach that we use in hypertension patients of DASH has been shown to be beneficial to these patients because it reduces the recurrence of development of calcium oxalate stones. So option number B is the correct one. C says low oxalate diet. That makes sense because you see lots of time these vegetables like spinach, for example, or potatoes, for example, staple food in India, spinach and potatoes are loaded with oxalate, and these people, you have to tell them that, you know, the vegetable that you're not supposed to eat or eat in very minimal amounts or sparingly is spinach and potatoes. So low oxalate in the diet also makes sense. So A, B, C are correct. Let's not check out the last option here. Low urinary pH predisposes to recurrence. I want you to remember, and I've said that in the main videos as well, that calcium oxalate stone, the most common kidney stone, is pH insensitive. All other type of kidney stones would either be due to acidic environment or due to an alkaline environment. Like I can talk about struvite stone. You see, Proteus bacteria is a urease producing bacteria. It's a urea splitter, so it's going to produce bicarbonate. It's going to produce ammonia, which is going to be an alkali. So in alkaline environment of the kidney, it is struvite stone that is formed. So either acidic or alkaline pH, both are going to be counterproductive and contribute to kidney stones. But which kidney stone is pH insensitive? Then it is calcium oxalate. So low urinary pH predisposes to recurrence is not a correct statement. And because the question here was saying which of the following is the correct one, so the correct answer for this particular question, the first one for this section, is option number 1. We can also do a quick practice of the various types of crystals that can be found in urine examination. So calcium oxalate, the hexagonal crystals, is easy to pick up. But if you cast a glance at the image which is just inferior to this, the crystals are much bigger. And the classical term that is used to describe this much bigger crystals is called as coffin lid appearance. In contrast, when it comes to uric acid stones are, I would say, very soft. Just like you know that cystine happens to be the hardest kidney stone, uric acid crystals are really very soft, so they can break up very easily. So there is no particular shape. I mean, though in the book he will talk about needle shaped, rosette shaped, but as such, I can say that there is no characteristic shape of uric acid crystals, no particular shape ascribed to them. The reason why I said that is because they're very soft and they can break very easily. In contrast, when it comes to cystine stones, where you would be having hexagonal crystals, and this is going to be the hardest kidney stone. So in case, I mean, the size is less than 2 centimeter, it's in the renal pelvis, and you're doing a lithotripsy, it may not break with a single session of lithotripsy, that is ESWL, or extracorporeal shockwave lithotripsy. Now, apart from the crystals, apart from the medicine domain, they can ask you regarding drugs which would be beneficial for patients who are having kidney stones to prevent a recurrence. I mean, after all, he's had a kidney stone, so he'll either go through a PCNL procedure or a extracorporeal shockwave lithotripsy, or if the stone migrates into the ureter lower one third, we can use a Dormia basket, and we can do his endourological procedures to remove the stone, which you study in surgery as well. But from the medicine domain, he can ask you, okay, what are the various types of strategies that can be deployed to prevent a recurrence of development of kidney stones. Then for calcium oxalate, your answer would be thiazides. The logic behind this would be that thiazides would cause a reduction in urinary calcium values. You see, I'll mention other drug which will make it easier for you to comprehend. When I was teaching in endocrinology, hypercalcemic crisis, like a person is having breast cancer or a person is having parathyroid adenoma, then calcium values will spike. Now, to kick out the calcium from the blood, we can use furosemide, because furosemide promotes urinary excretion of calcium. And just in the same breath, I would like to say that thiazides do opposite of furosemide. Furosemide causes an increased excretion of calcium in the urine, and thiazides tend to reduce the urinary excretion of calcium, which is why it would be beneficial for patients who are having calcium oxalate stones. Now, he can also ask you about what would you do in calcium phosphate. So the first answer of mine for calcium phosphate would be that, okay, I'll try to treat a parathyroid adenoma, because we need to, either the reason for calcium phosphate stone, there are two primary reasons why calcium phosphate stones could be developing in a patient. One could be distal renal tubular acidosis, which is also called as RTA1. Another reason for this would be parathyroid adenoma or hyperparathyroidism, as I am writing at the moment. I mean, I've not written adenoma, just it's trying to symbolize primary hyperparathyroidism is what I'm talking about. So we need to treat the basic fundamental problem, but then what drug can be used in this case? So for calcium phosphate stones which are having rosette shaped crystals, the answer would still be thiazides. Thiazides are going to be answered two times, calcium oxalate and calcium phosphate. And along with thiazide, we have an alternative approach. What we can also use is potassium citrate for these patients. Why citrate? Because citrate is a natural inhibitor. In fact, I can make a general statement. Citrate is a natural inhibitor for formation of oxalate as well as calcium phosphate stones. I said it prevents crystallization. Citric acid / citrate prevents crystallization of calcium phosphate and calcium oxalate. When it comes to uric acid stones, we need to maintain a pH of urine to be more than 6.5 on both day and night time. So initially what we can do is urinary alkalinization. The initial approach of yours should be answered as, I mean, obviously, in uric acid stones, if they're going to be recurrent, you are going to answer allopurinol, because the person could be having elevated uric acid, he could be having chronic gout. So because that is, I would say, relatively easier for you to comprehend and answer, so he can ask you regarding what is the initial approach that you would be doing in these patients. So alkalinization of urine will be beneficial in these patients. As I said, on a 24-hour basis, we need to attain a urinary pH of about 6.5 or more. And along with this alkalinization of urine, additional drugs which I can mention at the moment, which would be beneficial, would be allopurinol and febuxostat. Either of the two, I mean, I need to use xanthine oxidase inhibitor initially, or I can be using febuxostat to control the uric acid values which are spiking. And when it comes to gout per se, we do joint aspiration, and you read about negatively birefringent crystals, which would be, very characteristic way to, or very characteristic feature of gout. And the best way for diagnosis of acute gout is joint aspiration and not serum uric acid, because uric acid values can be normal during an acute gout attack. Now we come to triple phosphate stone, the composition of which is magnesium ammonium phosphate. And what we can do here is that we can use good quality antibiotics, and we can get rid of Proteus mirabilis, Yes, the organism that you read with swarming motility and dynes phenomenon, apart from Proteus, Klebsiella, and then Providentia, three important bacteria that can cause a triple phosphate stone. And for these patients, the first answer will be that you will use good quality fluoroquinolones, which are active against gram-negative organisms, so that you can handle this infection. But lots of time, because you see, answering antibiotics in this case is not a very big deal, so I'm not writing it. What he can, test your knowledge of pharmacology here is to talk about a drug which has a lot of toxicity from, I would say, initial perspective also. So I'm not saying that this is the best way, but this is one that's still given in Harrison, so I thought I should mention it. Acetohydroxamic acid can be used to prevent the development of triple phosphate stones, which develops in an alkaline pH. So you don't want to alkalinize the urine, rather you would like to acidify the urine. You see, in uric acid stones, I said initial approach is to alkalinize the urine, but do not alkalinize the urine with respect to triple phosphate stones, because rather it will increase the chances of development of a triple phosphate develops in an alkaline pH. So if you make it more alkaline, then the chances of crystallization will be higher. So I'm trying to do opposite, that is acidify the urine. And then for cystine stones, I think you would be aware from pharmacology that the drug we can be using in this case is tiopronin. And instead of tiopronin, another drug which we can be using is penicillamine. I'm not writing penicillamine because it has again damage to the kidney. So tiopronin will be the first answer as given in Harrison. So not too much of data to remember. Thiazide is answer to two of them: calcium oxalate and calcium phosphate stone prevention. That is to prevent recurrence of these stones. Uric acid, alkalinization, and allopurinol xanthine oxidase inhibitor. Triple phosphate acetohydroxamic acid and cystine stones would be tiopronin and penicillamine. The subsequent question says, what does the following angiogram in a 30-year-old hypertension patient show? So he's given you a renal angiogram, and when you scroll through, you are able to notice that the renal parenchyma looks fine. But when it comes to the renal artery architecture, I would say that there is some irregular appearance or a beading present along the course of the renal artery. This, I would say, chain of beads appearance is very characteristic for fibromuscular dysplasia. Now, how am I ruling out atherosclerosis? I can say that atherosclerosis, if it is responsible for renal artery stenosis, one, the age of the patient would be on the higher side. So suppose this question was mentioning about a 60-year-old smoker, I could have thought about atherosclerosis contributing to renal artery involvement and a possible renal artery stenosis in the patient. And why was the angiogram done in this guy? To scan for, maybe because he was hypertension, because he is a hypertensive patient. So we wanted to rule out renal causes for hypertension. And it's not that I'm trying to rule out option number B only on the basis of age and atherosclerotic risk factors. I'm also ruling out option number B because atherosclerotic narrowing of the renal artery mainly causes a proximal segment narrowing. In this particular case, you can notice that it's mainly the middle segment and the distal segment that is having an irregular appearance, whereas atherosclerotic narrowing mainly causes a proximal segment. The initial start of the renal artery is only narrowed. When it comes to Takayasu's arteritis, yes, it could be a cause, but why am I ruled it out is because Takayasu's arteritis mainly causes the ostial narrowing. So in this image, I can say that it's very difficult to pick out whether there is a ostial narrowing or not. But what we can pick up is this irregular surface, which gives more credibility to the diagnosis in this particular case as FMD, though it's a relatively a rare case for diagnosis for renal artery stenosis, especially from Indian perspective. Because in India, most of the time, the cause will turn out to be either, if it's a very old man, it's going to be atherosclerotic narrowing, or it's going to be Takayasu's arteritis. And non-specific arteritis is an alternative term to describe Takayasu's arteritis only. So C and D are two options which are like alternative names of each other, is why I have ruled out. Option number B I have ruled out because of one, age, then no mention of any atherosclerotic risk factors, and then a proximal narrowing, and then the classical finding of a chain of beads, I would say, would be though it's very difficult to pick up those classical appearances. In the exam it's not gonna be like very clear distinct images, so I've deliberately kept this one so that you can pick up the age part, hypertension patient, and then pick up that he's trying to ask you about renal artery stenosis per se. For unilateral renal artery stenosis, we can be using calcium channel blockers and ACE inhibitors. But in bilateral renal artery stenosis, you very well know ACE inhibitors are contraindicated. And most of the time in bilateral RAS, we will have to do a PTRA, that is a percutaneous transdermal renal angioplasty. And along with this PTRA, stenting of the renal artery would also be required. The correct answer to the current question in the slide is option number A. And then what I've done is I have shown you an image One of them is obviously a repetition of what was present in the previous slide, where the middle part of the renal artery, or the initial part where it's entering the renal parenchyma, is having this irregular distortion. But then they gave an image in which you can notice the smooth outline of the renal artery when it is entering into the renal parenchyma. But I think you can pick up these small, chota dilatations of the branches of the renal artery per se, which I can call as microaneurysms. The moment I say the word microaneurysms, I think it rings a bell, and you can pick up that the disease that I'm talking about, which would still be causing kidney involvement and would be causing hematuria and renal failure, is polyarteritis nodosa, where the branches of the renal artery are undergoing a dilatation, whereas the initial image, which is currently shown on the slide, is for fibromuscular dysplasia, where the standard chain of beats description is present. Moving to the next one. When you look at this specimen, you can pick up grossly dilated kidneys, large number of cysts which are present on the kidney per se. I mean, I can say that the corticomedullary differentiation, normally the cortex and the medulla differentiation is visible, but in this image, you are having large number of cysts. One of the cysts is also appearing black. I mean, this cyst which is appearing black is because they might have been bleeding long time ago in the cyst, and then the blood will break down to produce hemosiderin. So that's why the appearance of the cyst is black, and there's a complete loss of corticomedullary differentiation. So the image is straight away telling me that he's talking about polycystic kidneys, and because he's talking about a 25-year-old individual, I am taking it to be autosomal dominant, which has an adult presentation of polycystic kidney disease. He says, what is the leading cause of death in this individual? So guys, do not answer uremia as yes, uremia will occur. End-stage renal disease will occur in these patients. There will be a significant decline in the GFR of these patients to the level that they might require either a hemodialysis 3 times a week, or these patients might have to be subjected to a allogenic kidney transplantation. But the point is, uremia will occur very late. Initially, why these patients will come to you is because there is cysts in the kidney. So total, I would say, glomerular filtration rate is reduced, and this will cause a positive stimulus to the RAS system and will cause a high renin hypertension. This high renin hypertension will cause a left ventricular hypertrophy in these patients. So cardiovascular complications are one of the leading causes of death in autosomal dominant polycystic kidney disease. The correct answer for this one is option number B. We do have intracranial aneurysms present in this patient. One of the extra renal manifestations of ADPKD is an intracranial aneurysm, and that can rupture at any point of time. So it can cause definitely a subarachnoid hemorrhage, no doubt about it. But it does not happen to be the leading cause of death. The initial presentation of the disease, most of these patients initially present with flank pain. Along with this, higher incidence of urinary tract infection will be there. And then apart from this, they can be having stones. And a lot of these patients might be diagnosed when they start having daily headaches. They thought it is stress at office or pressure or tension on daily life. And on follow-up, when they were checked, their blood pressure was checked, they were found to be hypertensive. So the leading cause of death in chronic kidney disease, leading cause of death in person undergoing hemodialysis, leading cause of death in autosomal dominant polycystic kidney disease is enhanced cardiovascular mortality. 3 diseases, which I'll repeat again, where you have enhanced cardiovascular mortality as number 1 cause of death. In fact, I can mention 4: diabetes mellitus, silent MI can occur. So enhanced CV mortality, then CKD, which is again because of diabetes mellitus. Any person undergoing hemodialysis for any reason, whether it is renal artery stenosis bilateral, and he's undergoing a hemodialysis, ischemic cause of damage to the kidney, glomerulonephritis, diabetic nephropathy. The point is, any person who's having ESRD or is having chronic kidney disease undergoing a hemodialysis, enhanced cardiovascular mortality is present, and even in ADPKD, which has currently been discussed. So all other points are present, but is not the leading cause of death. Moving to the next one, he said a person is scheduled for hemodialysis. Hemodialysis, one session will be for approximately 4 hours. It's usually a range from 3 to 4 hours. I've said, I would say upper limit of 4 hours, and it has to be done 3 times per week. Because you have to cannulate the patient again and again. If you use a single vein for access, it can undergo thrombophlebitis. So before we do hemodialysis in a person, what we need to do is we need to connect the radial artery of the patient to the cephalic vein. The advantage of doing this activity is, if you connect the radial artery to the cephalic vein, what are you trying to achieve is that you are trying to make the vein become more rough and tough. By saying that I am trying to make the vein more rough and tough is that when artery will send blood in the vein, it will cause a change in the internal lining of the vein. This change in the internal lining of the vein is called as arterialization of the vein. The advantage of this arterialization of the vein is that it reduces the chances of development of thrombophlebitis. You see, as interns, you keep on putting cannula so many per day. I mean, you would be expert to the level that even if you are sleeping, somebody wakes you up and asks you to put a cannula in a person in whom most of the veins are thrombosed. You guys are, skilled enough to do that. But in hemodialysis patient, if I try to get a vascular access like through a vein and then I try to do a hemodialysis, the vein will collapse and the thrombophlebitis component will ensure the fact that I cannot cannulate that vein again. So if I have to do a procedure multiple times, I need to make the vein more sturdy, and that is why I said that we need to connect the radial artery to the cephalic vein. And guys, this procedure was described by a doctor in the honor of whom we call this as seminobrestia fistula, and that's what you see here, that the artery and the vein, the radial artery and the cephalic vein, have been, with the help of a surgeon's help, we have managed to connect the two. Let me just, to make this more comfortable, let me just draw a quick sketch here. Let me say this is the radial artery of the patient. And then in blue, I'm showing the cephalic vein. And let me say, due to surgical reasons, whatever, if we are not able to create a fistula, we're not able to connect the two, then what we can also use is PTFE. PTFE is the polytetrafluoroethylene. You know, artificial blood vessel, right? That vascular graft of artificial blood vessel is PTFE polymer. So we can use that PTFE polymer, and what it will do for us is that it will create this fistula. Once again, though I am saying at the moment we are using a graft here, so either arteriovenous fistula or a graft would be deployed so as to ensure this arterialization of the vein and reduce the chances of development of thrombophlebitis, and therefore the same site can be used for a longer duration. This is a classical name to be remembered, that in hemodialysis, seminobrestia fistula is created. It will take a couple of weeks for this fistula to harvest. How would you know that it is harvested? Like you grow crops, they harvest, and then you cut those crops and eat them. Similarly, here what I'm trying to say is that this fistula has to harvest. That is, when you connect the artery to the vein, I'm not saying that you can use this site from tomorrow only or maybe after 3-4 days. It will take a couple of weeks for the site to harvest. So there would be a bruit that the person, you guys can obviously auscultate, the person can feel a bruit. And how would you tell a non-medico what is a bruit? So you will just tell him that it feels like purring sensation of a cat, like a cat is purring. So when you put, if a cat is purring and you put your hand over the cat's head, you can feel that vibration under your fingers. A similar kind of sensation can be felt with respect to a bruit. And obviously you can auscultate it, and you can do a Doppler to check that there is a proper patency, and then subsequently the site is ready, it's mature, and it can be used for taking a vascular access and do hemodialysis at the frequency that I have mentioned before you. The correct answer to the current question on the slide is option number A. Coming to the next question, he says the following appearance on micturating cystourethropy would be diagnostic of. So you need to scan through the wall of the bladder, and I think you will agree that the wall of the bladder is very irregular. And because of this, I'm going to use this term, Christmas tree appearance of the urinary bladder, and that would help you in nailing the diagnosis in this case as well. UB here stands for urinary bladder, which would be neurogenic bladder. Now, how would posterior urethral valves look like? I'm just going to show you an image for the same. So let me just change the slide. You see, if they're going to give you an image with respect to posterior urethral valves, then wherever there's a posterior urethral valve, proximal to that, the proximal part of the urethra would be grossly dilated, and then there could be a bladder diverticula also present. So and in posterior urethral valves could be associated with a vesico-ureteric reflux as well. So the current slide, that the one that I'm currently showing to you at the moment, where there's a proximal urethra dilatation, wherever there's a posterior urethral valve is PUV. Then this is obviously neurogenic bladder. The irregular appearance of the bladder is even more visible in contrast. When you compare with that of PUV, the surface of the bladder does not appear so irregular. And then if you look at the first image, very classical, doesn't appear to be too much of a problem with respect to the urethra. But when the bladder of the person is contracting, you are noticing when the bladder is contracting, some amount of urine is going in reverse direction upward towards the parenchyma of the kidney. So this would be very classical image for VUR, vesico-ureteric reflux. There are 5 grades of it that you need to reach from surgery, and the treatment of each one of them can also be asked. So vesico-ureteric reflux, the neurogenic bladder, and posterior urethral valve are 3 contrast-based studies that can be asked to you, and the correct answer to this question on the slide is option number B. Moving to the next one. Once again, the image that is coming up here is a post-mortem specimen of a person with autosomal dominant polycystic kidney disease, and he says all of the following are true about this patient except. So, because there are malformed kidneys, these people would be having a higher incidence of UTI, pyelonephritis, and kidney stones. The commonest type of kidney stone is calcium oxalate. But in autosomal dominant polycystic kidney disease, you do not get a calcium oxalate stone. Surprisingly, guys, the commonest type of kidney stone in ADPKD is not calcium oxalate, it is uric acid stone. The best test for diagnosis of this condition is a ultrasound, or we can also do a CT scan, but I've written CT later because lots of time these patients might be reaching end stage renal disease. So if you do a CT contrast study, then there is a possibility that the kidneys can shut down, though a plain CT would be able to very well delineate the physical appearance of the cyst. So both ultrasound and CT are good enough for diagnosis. You need at least 2 cysts to be present between 30 to 60 years of age, more than 4 cysts after 60 years of age for diagnosis. And nowadays, we do not do a intravenous pylography for these patients because of the risk of anaphylaxis with the dye. But in earlier times, when IVP used to be done, we used to get this classical appearance of spider-like appearance. Because the kidney is damaged, the production of erythropoietin is going to be hampered. That will explain the anemia component also. So three of the options are right. He says what is wrong. As I explained to you, these patients are going to have a stimulation of the RAS system, you see, because there's a progressive decline of GFR. Therefore, the renin would be upgraded, aldosterone would be upgraded, angiotensin 2 would be upgraded, which will explain the hypertension. So what you do not get in these patients is a low renin. It's rather a high renin hypertension. A condition where I've described that there is a low renin hypertension is a differential diagnosis discussed in endocrinology with respect to Conn syndrome, that is Liddle. In Liddle syndrome, the problem is with the channel. Epithelial sodium channel works all the way extra. So there's more salt and water in the body, and that extra salt and water causes a negative feedback to appear, which causes low aldosterone, which causes a low renin hypertension in the person. So do read about Liddle syndrome from the endocrinology component in case you're going through the main videos. In the kidney part, after electrolyte imbalances is where I've talked about Bartter and Gitelman and Liddle syndrome in a comparison. But then this Liddle is talked about both in endocrine as well as in the kidney section as well. The correct answer for this question is option number D. I mean, where do you get a low renin hypertension? The peculiar thing is you always get a high renin hypertension. No, all the parenchymal diseases of the kidney and vascular diseases of the kidney always contribute to a high renin hypertension. But we read about low renin hypertension with respect to Liddle syndrome, which would be a epithelial sodium channel defect. So these are the details that I would like you to remember for this topic. Thank you so much for your patience and hearing me out.